that I don't make a dime off of this. Okay. I just want to start out with the notion that drug testing in general is massively important, I believe, in what we do, in the work that we do. And not necessarily coming from that point of view where I can't believe drug users for what they say, because I don't really like starting from that standpoint with my clients. But sometimes people don't even know what they're using, they don't know how much they're using, et cetera. And so I think, like in any medical sort of treatment capacity, testing is the thing that allows us to really know what's going on with our clients. So if I was treating people for diabetes, I would test their glucose levels. I'm treating people for drug use, so testing is king in that way. But there are many, many different ways of testing, and what I put up here is a little chart that is kind of hard to read because the size of this, but essentially what I have here is ease kind of moves along this continuum. If you ever handled urine, you know why that's on the low end of ease. But then, the time window within which you get to catch, quote unquote, any metabolites actually moves in this direction. So breathalyzers work for a very short period of time, all the way to your analysis. And actually, if I would have put hair analysis on here, it would be even longer. And then you have the temporal specificity. Along with that long time window, one of the things that is not all that great about, let's say, your analysis is you don't know when the substance use happened. And for anybody who deals with your analysis on a regular basis, you know that actually the levels don't even tell you all that much, other than the fact that there's metabolites present, because individual metabolism rates, differences in liver enzymes, et cetera, completely alter what you'll end up finding. So every drug testing method comes with its own pros and cons. And one of the things actually that I didn't put on here that is very important are the kinds of drugs that you can actually analyze. So breathalyzers, as of right now, are only relevant for alcohol. Your analysis out of the three that I present here is the most comprehensive in terms of the metabolites that you're able to discover. The reason that was the last important part to go back to is, we talked about this before the presentation with some of you, and we focus a lot on drug use and methamphetamine use or opiate use. We talk a lot about overdose deaths, especially in the United States, for prescription drug use, moving on to opiates. To heroin, but if you look at the overall picture, again, really hard to read the text over here, this says alcohol right here, and we have 88,000 estimated annual deaths from alcohol abuse. Compare that to essentially all other drug overdoses, and you're dealing with something closer to about 35,000, so less than half as many deaths from essentially all other drugs. You look at opiates, which we've started caring a lot about, and it's literally about 1/6 of the amount of deaths that we have from alcohol. And so even though other drugs are monumentally important in the overall picture, when it comes to some of the human costs, I think alcohol is still the big hitter in almost every country that I know of. And so I want to focus a little bit specifically on that. My IOP center, without a doubt, 80% of the clients that we see are primarily coming in for alcohol. Oftentimes there's tangential drug use along with that, but the primary presentation is often for alcohol. When we look at testing, the setting is also massively important. We had a presentation on a bunch of different treatment settings. If you're in criminal justice, one use and you're out. So you're breaking probation or parole, and the indication, you don't care about temporal specificity or any of those sorts of things. You just want to make sure that there are metabolites present. If there are metabolites present, you've broken the rules and go back to jail, don't collect $200 on the way in. And that's important for that. Thank you. That's important for that specific setting. Let's say if we go into residential, your analysis can give us those urine cups that do a relatively, if you use a 13-panel cup or something along that line, a pretty comprehensive immediate test. Very important to do a confirmatory analysis with that, right? Because we know we can get a good number of false positives and or negatives. Breathalyzers are sometimes used, but really when you think about it in a monitored setting, not all that important, because much harder for people to sneak in drug use while they're in that setting. Not impossible, but harder. I'm going to focus on outpatient treatment. You're probably not surprised because that's what I do for a living now. So that's where I'll put my focus. But in an outpatient setting, we run into a problem. We don't see our clients all the time. We see them 2 to 3 times a week. So there's a testing window, and your analysis can miss many, many of the drugs. Saliva testing can absolutely miss because it gives you about a 24-hour window. Breathalyzers, for the most part, have been considered to be impractical, because when you see somebody 2 to 3 times a week, they come in. I mean, you have to be pretty hard up to drink alcohol an hour or two before coming into treatment, and that's all the breathalyzer was able to catch. But I'm here to talk about a different way of doing this and update some data that I showed last time, because there is another way. You know, we're in the age of technology, as I'm sure all of us know, as we're taking pictures on our phones and checking Twitter while I talk. But there is another way to do this, right? We now have mobile breathalyzers that sort of take this drug testing out of our hands, literally, and move it into the world. And they introduce us to a whole host of methods. I'm showing here a more consumer-level breathalyzer that connects to an iPhone, to the device that we actually use called the Soberling, all the way to the Scram that Lindsay Lohan made famous by wearing on her ankle. But that gives us, the Scram gives 30 tests every 30 minutes based on sweat production. The breathalyzer, like I said, that we use is this guy right here. It's a pretty incredible piece of technology that'll get smaller, I'm promised. But right now it's about the size of 2 or 3 stacked iPhones. But the beautiful thing about this is you get automated reports either through a mobile network or through the iPhone's Wi-Fi capabilities, photo identifiable with facial recognition. It gives you blood alcohol level, which I think is much more important than whether or not somebody drank. It's actually important to have some sort of BAC level. And for outpatient settings, no office visit required, which has been incredible for what we've been able to do, because we can give this to clients to carry, and they give us 3 to 4 readings a day, and I'll present some data on that. This is a version of the software where you get to set somebody's testing schedule. You get to decide whether or not you want them to have to retest if they test positive for alcohol, these kind of things that are really, really cool in an outpatient setting especially. It's also GPS equipped. I'm just waiting for the day where there will also be an add-on module that tells you if they're home or work or in a place they specifically told you is one of their favorite bars, etc. We're not quite there yet. Okay, let's go to actual data though, because I have absolutely zero stake in Soberlink as a company. There are other devices that do a similar thing. But a study in 2011, or published in 2011, looked at this within a criminal justice setting using 4,000 offenders. And you look at breathalyzer tests, they came back 99.4 alcohol-free. Among the people who did test positive at every given point in time, 2/3 only tested once positive. Why? They tested the technology, they found out that it will catch them, and they stopped because they didn't want to go to jail or prison. Almost nobody, I mean literally within this population, 20% of people testing multiple times positive for alcohol, and you're looking at 2 tests, 3 tests out of an entire period of probation. Pretty incredible when you think about it. Transdermal testing came back actually 78% substance free. And when you think about that, part of that has to do with the higher level of accountability, right? So the transdermal testing tests at 24 hours, 7 days a week. So one of the things that shows us is one of the limitations probably with breathalyzer testing, and that is unless you're testing literally every hour, there is a window for people to use, and I'll talk about that a lot more in an actual outpatient setting, because like I started out saying, setting is a really important part of this picture. Criminal justice clients are highly motivated not to fail tests. This is almost akin to physician treatment for substance abuse, right? High success rates. Why? Because people don't want to lose their board license, and so they follow through much more significantly. You'll do, I mean, I can tell you this from personal experience, you'll do almost anything in the world to avoid that place, especially after you've seen it once and you don't want to return to it. That also means that they're motivated to cheat, so that's where we have that 20% difference, because if you're gonna be very motivated to, if you drink, make sure that you drink within the windows that are allotted using a breathalyzer. These are finding in an outpatient setting, not including us. This compares self-reported drinking episodes, urinalysis for ETG/ETS testing, and the cellular photo kind of technology. 98.9, virtually every self-reported drinking episode was confirmed by a breathalyzer. Only 2% of those were actually caught, quote unquote, using urinalysis because of the time window. If anybody knows anything about ETG testing, you get about a 72 to 80 hour window or so, but now we're getting more and more evidence that it's actually more like 48 hours. So horrible sort of horrible accuracy, horrible validity there, right, in the urinalysis version of this. Again, the thing that's important to note in this is all based on self-reported drinking. So the question was, okay, we're going to test you, did you drink or not? And then here's a breathalyzer, and oftentimes people knowing that they're about to be tested would tell the truth. I'm going to show much more comprehensive data. This is not a huge sample size. We're talking about 40 participants, but it's a whole slew of testing because we're talking about something like a year of 3 times a day testing across numerous clients. So I'm going to break down, I know there's a lot of data on here, and I'll break this down a little bit. So here's my overall sample, here's my abstinence clients versus my moderation clients, and one of the things that I think is important, or was important for me in looking at the data about whether this is a technology I want to use is it a valid measure of drinking? So there are some things that I'll point out along the way here. So again, all our clients start with 3 times a day testing. After they do well for a specific period of time, we might reduce that to 2 times a day, morning and evening. I have a pretty high-functioning group, so not a lot of day drinking in my group, but it happens. I excluded 4 clients that had 2/3 of their tests missing. My reasoning was that means they took less than 1 test per day. I actually think 1 test per day is a pretty good assessment because most of my clients, once they, and I think those of you who deal with alcohol on a pretty regular basis, once they start drinking, typically they have a really hard time stopping, so even 1 breathalyzer per day will discover drinking. You don't need 3 or 4 tests a day. But if they didn't take at least once a day, I excluded them. So again, this is an outpatient, private pay, no mandated population. I want you to keep that in mind. 2/3 of the tests that are submitted are alcohol-free. The other third is primarily missing, by the way. It's not showing alcohol use. And even though oftentimes it's easy to kind of jump to conclusions and assume that those missing tests were all positive, I can tell you that a lot of these are sort of early morning tests and middle of the day tests. So without a doubt, I will promise you that some of those 33%, we're looking at 32.93% missing, some of those for sure were positive. I can guarantee that. I don't have really good data on which that is, and I'm going to work harder and harder on trying to uncover that. But that literally leaves us with about 2% positive tests out of tens of thousands of tests that we've done at this point. This is one of the nicest validity measures for me, and that is 46% of our abstinence clients never submitted an alcohol positive test versus 16.7% of our moderation clients. And that's something that you would expect, right? Moderation clients, by definition, are expected to be drinking more. And so, to me, that's a good validity measure, showing that the technology is actually able to disambiguate which group people belong to. The maximum number of positives for our clients, only 6 in our abstinence groups. Again, that includes the fact that 2 of these clients had a whole number of tests missing and drank quite a bit during their treatment. I just want to put in that caveat. And for one of our moderation clients, he is now at 108 positive tests, but he's been in treatment with us for a year and he's drinking actively, so that would be expected. So here are the numbers. This is, again, the overall numbers I gave, 65 and 33% for alcohol-free and missing tests. These percentages right here are actually, and I can share the numbers with you if you want, are actually only of the subset of people who drank. So you'll still see that 1 test is a pretty common finding. Again, this is 5+ tests. Among the people who drink, about half of them overall in our sample are providing a large number of positive tests, but that is coming solely from my moderation group. So you'll see in the moderation group, 2/3 of my clients who are in the moderation group give 5 or more positive tests, as expected because they are active drinkers. In the abstinence group, only 7% of clients provided 5 tests or more over an entire period of treatment. So this is showing me that this is a valid and reliable measure because I'm getting consistently reliable assessments based on the categorical treatment goal for the clients. But also, more importantly, I think it's hard for, there's no control group, right? This is a self-assigned groupings, so I don't know what would have happened. But on its face, one of the things that this suggests, and I would love to be able to do a randomized controlled trial of this, is that this is a nice accountability measure for our clients outside of the clinic. And honestly, for a clinic that runs moderation options for when people are actively drinking. This is one of the only ways that we feel, quote unquote, safe doing this, because we do have some accountability. I tell my clients all the time, if you drink, just blow in the breathalyzer. Nobody's going to kick you out of treatment. You're just giving us an assessment of what is really happening with you in terms of your alcohol consumption. Some other data showing that what we're looking at is, that we're actually looking at some valid measurements of what's happening here. This is the mean BAC, the average blood alcohol concentration that we're getting in our readings. This is my abstinence group. This is my moderation group. I think you would expect my moderation group to have a higher mean BAC, and you do, and it's a highly significant finding, obviously. This was actually interesting for me. This is max BAC. This one, I guess my original hypothesis was that my abstinence group would actually have a higher maximum BAC, because my thinking was following the abstinence violation syndrome, that people who are seeking abstinence but relapse will end up drinking at excess more than moderation clients who are actually, quote unquote, allowed to drink and end up relapsing. I was wrong. A significant difference with the max BAC actually leaning towards my moderation group. If you look, it's hard for you guys to read the numbers, but this line right here for max BAC, so the median max BAC is about 0.11. Seriously, that's the equivalent of about 4 drinks, about 0.025 per drink. I'll tell you this, if this is the biggest problem I have to deal with in outpatient setting for alcohol, is a median score of about 4 drinks, I feel like we're doing a pretty good job. I think we had presentations the first day with 15, 20 drinks per day on average for some of the higher level drinkers, and we see that at the beginning as I presented with the case study on the first day. So I'm actually relatively okay with a max BAC of 4 alcoholic drinks. The nice thing about our abstinence group is that number is actually lower. It's about 2 drinks. So I was wrong, but yet all the levels are far lower than I would have expected them to be for max BAC. We do see, if you look up over here, this is a histogram. So these are my medians. I'm sorry that the size is so small. But this max, we do get up to about 10 drinks worth. So if you look at this level right here, it's about 5% of our moderation clients end up getting to those levels. But I'm pretty encouraged with the medians. So look, in the end, like I said, I'm not promoting a product. What I'm promoting is a different way of thinking about measuring what it is that we're doing. The first day I was here, the main thing I was talking about is maybe we stop looking at abstinence as the only important outcome in treatment. And so I actually completely ignored alcohol use in that first one. I didn't talk about it once. This time I'm focusing on the alcohol use, but I'm suggesting something different, and that is we have technology nowadays to allow us to move testing out of our hands. Get away from this point where testing is a punitive, suspicion-based, clinic-based assessment method, right? You don't have to go to your doctor every day to get your blood glucose measured. That would be shaming, inconvenient, and awkward, right? If every single time you had a cookie, you had to go to your doctor and say, hey, I ate too much sugar. Instead, we have methods to be able to do this at home. It's still an accountability measure. It still allows people to engage in more treatment when they need it and less treatment when they don't. And we now have the technology. People are working on breathalyzer forms of additional drug testing. So we, I don't know because I'm not involved in it, but I think in the next 5 to 10 years, we'll see additional metabolites that can be tested for using breath. And that will be really, really wonderful, because in the end, I'm hoping that what I was able to show is we're getting good detection rates, we're getting high validity in terms of actually discovering substance use, alcohol use when it's happening, and this is a highly flexible method of being able to test. It overcomes, especially for IOP, the limitation that we end up having in terms of frequency and office visit limits. And so, yes, testing is very, very setting dependent. The presentation that happened earlier today in the morning suggested, and I believe in this, that IOP treatment methods are actually highly valid and should be utilized more, because they're less restrictive forms of treatment that allow people to continue being engaged with school, work, etc. But I think this technology right here is one of the things that will allow us to overcome one of the primary limitations, which is when you're in an outpatient setting, you know less of what's going on with your client. I think this can bridge the gap a little bit. Thank you.